In most health conversations, weight loss is celebrated. It's associated with fitness, discipline, and reduced risk for chronic diseases. But in the context of cancer, especially advanced cancer, that same weight loss can be a red flag, not a victory. This is the paradox of cancer cachexia, a complex, often irreversible metabolic syndrome characterized by involuntary weight loss, muscle wasting, and systemic inflammation. It is not caused by lack of food alone and cannot be reversed simply by eating more. Yet many patients and even some caregivers overlook the warning signs, assuming that shedding pounds is somehow beneficial or inevitable. In truth, when weight loss is driven by cancer rather than intentional lifestyle change, it often signals worse prognosis, impaired treatment response, and higher mortality. Cachexia affects up to 80% of patients with advanced cancer, especially those with tumors of the pancreas, stomach, lung, and esophagus. It involves more than just fat loss. It strips the body of skeletal muscle, weakens the immune system, and compromises physical function. Patients may appear thin but are metabolically inflamed, profoundly fatigued, and increasingly unable to tolerate chemotherapy or surgery. Unlike ordinary malnutrition, cachexia is not easily corrected with calories alone because it stems from underlying tumor-driven metabolic disturbances. Inflammatory cytokines such as IL-6 and TNF-alpha disrupt appetite signaling, increase energy expenditure, and accelerate protein breakdown, creating a vicious cycle of wasting that no amount of supplements or smoothies can easily fix. This misunderstanding, treating cachexia like a dietary problem rather than a systemic one, leads to serious clinical oversights. Too often, weight loss is ignored or minimized until it reaches a crisis point. Some patients themselves resist nutritional support, either due to nausea, taste changes, early satiety, or the cultural belief that thinness equals health. Others are encouraged by friends or online communities to maintain clean diets that are low in calories and protein, inadvertently fueling further wasting. In late-stage cancers, attempts at restrictive or detox-based diets can accelerate decline rather than promote healing. The result: weakened immunity, reduced mobility, increased hospitalizations, and premature death, not from cancer directly, but from the body's collapse in trying to fight it. Nutritional intervention must happen early, long before visible wasting begins. This means screening for signs of malnutrition at the time of diagnosis, monitoring body composition, not just weight, and involving a clinical dietitian as part of the oncology team. Calories matter, but so does protein quality, micronutrient balance, and meal timing. In some cases, medical nutrition therapy such as high-calorie supplements, appetite stimulants, or even enteral/parenteral feeding may be necessary. These are not signs of failure or giving up. They are tools to keep the body resilient enough to survive both the cancer and its treatment. Unfortunately, the broader wellness culture can obscure this message. With the popularity of intermittent fasting, ketogenic diets, and plant-based cleansing protocols, it's easy to forget that not all weight loss is healthy. For cancer patients, especially those undergoing aggressive treatment, the priority is not a lean physique. It's metabolic stability, muscle retention, and energy preservation. Trying to optimize nutrition through fads rather than evidence can backfire catastrophically in this population. Moreover, medical professionals themselves often underemphasize nutrition in cancer care. Despite abundant research showing that early nutritional intervention improves outcomes, delays in referral are common, and oncology clinics may lack dedicated nutrition staff. This systemic failure allows cachexia to progress unchecked, often until it is too late for reversal. By the time patients are visibly emaciated, the underlying muscle and metabolic damage has usually become irreversible, and quality of life plummets. The grim reality is that cancer cachexia contributes to death in up to 30% of cancer cases, not because the tumor spreads, but because the body can no longer maintain the basic functions needed to survive. It is not merely a side effect, it is a terminal pathway. Yet it is underdiagnosed, undertreated, and underestimated. Weight loss, in this case, is not a sign of progress. It is a sign of a system in collapse. In conclusion, the difference between healthy weight loss and cancer-related wasting must be made starkly clear. Cancer cachexia is not about aesthetics, and it is not about willpower. It is a metabolic emergency that requires medical, nutritional, and sometimes pharmacological intervention. For patients, families, and clinicians alike, the message must be unambiguous. When it comes to cancer, unintentional weight loss is never good news. It's a call to act, and act early before the body slips past the point of recovery.